proceed to our next talk, and which will be Professor Ulunay, and he'll be talking about posterior shoulder instability. It's not always the labrum.
Morning. Thank you again for invitation. This wonderful city of Lahore. I'm going to present you posterior shoulder instability that is not because of the lateral lesion. Most of the posterior shoulder instabilities are caused by lateral lesions, but other than lateral lesion, we see bony problems that can be happen in three ways. I'm going to explain this in my talk. Posterior instability of the shoulder is not that much seen as anterior instability. It's about 1 or 4%. But this is not that you can always see, or you can frequently see posterior lateral lesions with anterior lateral lesions. That is a different topic, but posterior lateral lesions can be seen frequently. But the instability of posterior due to bony insufficiency is really uncommon. But because of the anterior bony Bankart or Bankart only bone erosions is much more, we have some methods to measure these defects. But for the posterior part, we don't have a standard method to measure what we are dealing with for the posterior part of the glenoid mostly. Although the anterior insufficiency is well defined, the posterior sufficiency is not well defined. We don't know how to find the defect or how to measure it, and when we should put a bone to replace this defect. I said that we see three types of bony problems of the posterior glenoid mainly. It can be traumatic, acute traumatic, or dysplasia, or erosion. Traumatic ones are the better ones, because in this patient we have a posterior dislocation with a fracture, so we can repair it laparoscopically. So these are the best patients for us for posterior bony Bankart lesions, acute, traumatic, with dislocations of posterior. This is very simple to repair it, and the results are very good. And the most challenging is the dysplasia of the posterior glenoid. In this patient, you can see that there's a posterior dysplasia, and there's no bony to hold the head in the joint. So these are the most challenging problems of the posterior glenoid. You can see this is the arthroscope of this patient. You can see that there is no support of bone posterior, and if you do an internal rotation, you can see that it goes posterior easily. How we can deal with this problem? We can do an wedge osteotomy, you can put a bone block, but the overall results of this type of problem or instability caused by dysplasia, the results are not good. Also, if the patient has voluntary dislocation, he can dislocate and relocate he or she's shoulder. If there's a ligamentous laxity combined with dysplasia, connective tissue disease, or voluntary, these patients you must be avoid to operate them. The rehabilitation and physiotherapy and psychiatric support is the main treatment option for these patients. The main problem that we face mostly is the posterior glutenate erosion that can be missed in most of us. You can see that there is a bone erosion on posterior side of the glutenate, and the humeral head dislocates posteriorly, and there is no support on posterior side of the glutenate. And you can see from the tomography there is an erosion of the posterior bony glutenate. So we have to put something to replace this erosion. For the anterior part, yes, we have some surgical techniques like Latarjet, bone block surgery, but the posterior part is not that well defined. What we are going to do with bone loss, recurrence, when we must go put a bone block for posterior instability is not well defined. But the story of posterior bone block surgery is since 1931, Russia put a rib autograft to replace this defect. And there are iliac grafts in 1943, and now we are mostly using this bone block techniques. Bone block techniques can be used in two ways. You can put the bone block there with open procedure, iliac bone block graft, iliac crest bone graft, or arthroscopically. How to fix it? You can fix it with screws, or you can fix them by using suture anchors. Two techniques are available and proven. Why we choose an arthroscopic procedure for this problem? Because maybe it's cosmetic, but it's not the main goal, main reason that we choose this problem. We choose this technique. You can see the defect very clearly. You can, in some cases, you can protect the labrum also, if there is a labrum left. And the other pathologies can be diagnosed very, very easily. There may be huge reverse Hill-Sachs lesion that can be treated by reverse remplissage, which is called McLaughlin procedures. You can medialize the subscapularis. If there's a slap lesion, you can repair the slap lesion. And if there's an anterior instability accompanying it, yes, you can repair also the anterior instability. And if there's a posterior labrum tear, as I told before, you can also repair that simultaneously. This is a case. This is a revision case. There's a bone. You can see there's a bone defect on the posterior side of the glenoid. We mobilize the labrum first, as we do for the anterior side. Now it's mobilized. We put two anchors inferior to the articular side. Then we introduce the graft into the joint, and then repair the labrum of it. So we can see the bone block is there, and inferior labrum is repaired. The posterior labrum was not that in good quality, so we cannot repair it over the bone block, but the inferior capsule was repaired. This is perioperative tomography, and on your right side is the postoperative tomography of the bone block. But in some cases, they are not too much. there may be both anterior and posterior bony resorption. And in this case, you can put an reverse shoulder arthroplasty, maybe. But if the patient is too young, you have to do something for these patients. Here you can see this is a revision case. We are looking for the posterior portal. Sorry, the writings are in Turkish. So we are removing the interval first. Interval is removed. You can see the coracoid, subscapularis. Then we put two anchors into the spongious bone. This is second anchor. Then we made a loop outside the joint, and we translate the graft into the joint. You can see this anterior bone block, this anterior side. You can see the labrum is there, and labrum is repaired on the bone block. Now, when we look at the posterior, yes, on the posterior side, we have no labrum and instability to the posterior side. In this case, you have to do something. The advantage of bone block is you take another block from the iliac crest and put it to the posterior side. You can see we are debriding the glenoid, then put two anchors into the spongious bone, first inferior, then posterior. Then we shuttle the bone graft into the joint. These are the anchors. And this is the posterior bone block. It's shuttling into the joint. And the nuts are tight there. This is after fixation. We have a bone block on the anterior side and bone block on the posterior side. And this is the pre-op and post-operative tomography of the patient. And 3D reconstruct of the tomography. When I look to the literature, this type of patients are not that much frequent. And there's only one with Lafos cases with 7 patients. The results are not that good. But for the young patients, if you don't want to put an reverse shoulder arthroplasty for them, you can try this technique. What are the results of the posterior bone block? The results are good for the instability, but degenerative arthritis may be followed in long term. And this is a report that 80% success. And in 24 shoulders, they're reporting that the recurrence is not too much, but the results are promising. Also, 80% success for posterior bone block. For conclusion, I can say that there's a consensus on anterior bone loss. What we have to do. There's a little bit consensus, not totally, but there's a consensus. But there is no consensus on posterior bone defects. And if there is an posterior bone insufficiency, you may consider using arthroscopic procedures to put a posterior bone block and repair the additional pathologies there. And if it is an acute case, if it is a traumatic case, you don't need to use a bone block. You just repair the bony Bankart, bony posterior Bankart, and this is the best. You can get the best result from this technique. And nowadays we don't have enough literature to give us what is happening afterwards if there's a posterior bone block, posterior bony deficiency. Thank you for your attention.